Are you routinely getting an ECG in patients presenting with seizures? This is often overlooked, but it is a critical piece of our management. And I'm not talking about EEG. I'm talking about ECG, and I know it doesn't sound right, but I'm going to give you two reasons why we should always get an ECG in a patient presenting with a seizure. Number one is that it can be difficult to differentiate syncope from seizure. We talked about this in a reel yesterday. Go back and check that one out. But we know that patients with syncope can have some brief generalized tonic-clonic movements. They can have incontinence. They can have tongue biting. It's hard to know sometimes whether you have syncope or seizure, so just get the ECG done because syncope should be on your differential. Number two is that even in patients with well-established seizure disorders on AEDs, we sometimes make a mistake. Even though that patient was diagnosed with seizures, they might have actually had syncope, and there are numerous case reports and case series of these things happening. Patients who were diagnosed with a seizure started on multiple AEDs only to have breakthrough seizure after breakthrough seizure, which once someone got an ECG done, was determined that they actually had a prolonged QTC or Brugada syndrome or an AV block, and unfortunately, drugs like keppra and phenytoin aren't going to treat that issue. The ECG is just a piece of paper. It's basically free, and we should be getting it in every patient presenting with seizure. Scour it for conduction abnormalities because you might find the patient's actual reason for presentation.